So this is a bit of a similar story as Ophelia was telling us this morning. This is Mamutsiletse from Lesotho. She's actually asked to go to the health facility once a month. She takes 3 hours to get to that health facility, and then she spends a full day waiting with other stable patients on ART just to get her treatment from a completely overburdened nurse who doesn't know how to deal with the big patient load that is waiting there to be seen by her. And actually that's stories like this actually made us as MSF to consider how are we going to go to deal with a growing cohort of stable patients on ART. And so that's why in different contexts we actually asked ourselves the question of how could we differentiate care for stable patients on ART. So this framework was developed after we did that actually, but it nicely resumes what I want to say. So basically we looked for stable patients on ART. What service intensity do they need? Do they really need to be seen by a clinician every month? Or is it just for ART refills that they're coming? We also looked at service frequency. Do we want them to come monthly? Could they be okay just to come 3 monthly or 6 monthly? We looked at which type of healthcare worker cadre do these patients need to be seen by? Is that necessarily a trained healthcare worker, or can that be a lay worker? And we tried to look at service location. Where could those services be provided? Are there certain services that could be provided at a community level, avoiding that the patient needs to come to the health facility, which is 3 hours away? And all of this, of course, is based on what does that patient need? What do those stable patients on ART need? So this exercise actually resulted in a number of different models that have been developed according to their context. So they were really context-dependent responses to the reality of patients. And we developed a number of models going from more health service driven strategies to more patient driven strategies, and I'm going to talk a bit through the details of them later. But the main thing that they all have in common is that they actually try to de-link clinical consultation from ART refill. So we try to see minimally what do these patients, stable patients on ART need. They need to come once a year for a clinical consultation and a viral load. And the refill, we want to de-link that from that yearly consultation. We're going to see how we can organize the ART refill in an innovative way. So as I said, all these models are context adapted and based on what patients actually need. And key in there as well is that it was also always a choice of a patient to enter in one of these models, yes or not. So a first model is what we call appointment spacing and fast track drug refill. So that's really a health service change in the system, change in the organization at the health facility, which has been piloted in urban as well as rural contexts, where patients come 1 to 3 monthly, depending on the context, for their refill at an individual basis. So instead of queuing up like this lady on the first slide was doing, they go directly to the pharmacy. They pick up their drugs, so they just wait in the queue to pick up their drugs, and in half an hour they can be out. They have their drugs in their pockets, and they can go home. So this drug refill is often done by lay workers, and then they just attend yearly for their viral load and for their clinical consultation. Another strategy that was piloted mainly in South Africa, mainly in urban settings, is what we call Adherence Clubs. And that's actually a grouped strategy for ART refill. So patients are grouped by 20 or 30. They meet every 2 months at the health facility or at a community venue in certain cases. And this group is led by a lay worker who then actually distributes the drugs to them. Again, yearly they come to the health facility for their consultation and for their blood drawing. But in between, they just get their drugs as a group. And again, it makes them spend maybe 1 hour and a half at the health facility or at the community venue to pick up their drugs instead of the 8 or 6 or 8 hours that they might spend there. Then a third strategy is what we call the community ART distribution points, or in French also called PODIs. And as this has been piloted in Kinshasa, Congo. That's why we call it PODIs. That was in an urban setting where we provided this, where patients come 3 monthly to a community art distribution point. So it's actually a network of people living with HIV who man that distribution point. And at that place, patients can again go with their receipt individually. They get the drugs from that peer person and can just walk home. Again, yearly, they come for blood consultation and viral load. So you're going to see that always comes back in the different models. And then a last one, oops, that grey thing wasn't supposed to be there yet, but community art groups is the last model that I want to present to you, which has mainly been started in rural areas, and it's in Mozambique, Tete province, where we first started doing that, where again, patients can get refill from changing from 1 to 3 monthly, depending on context, in group. So these are self-formed groups of patients who actually rotate on a monthly or 3 monthly basis for drug pickup. So we meet in our village or in our community, and today, I'm going to be the representative to come and pick the drugs for in the health facility for my group. And when I get back from the health facility, I distribute them to my other group members. So this is really a fully patient-led model. There's no paid lay worker involved in that in the community, and again, these people come then yearly for their clinical consultation and viral load. You're going to see that the art refills differ along these models. Basically, we've always been forced to follow the maximum duration allowed by the Ministry of Health. And in absence of viral load monitoring, we're actually using CD4, and patients have to come on a 6 monthly basis for blood drawing for CD4 and their clinical consultation. Now, what are the benefits for patients and for healthcare workers across these models? First of all, I think, and most importantly, it reduces the burden for patients. As this group member of a community art group in Mozambique said, the advantage of being in what they call a CAG is that you can do other small jobs when you know that there's somebody else who's going to pick up the drugs for you. So they can continue doing the regular things they do in life and lead actually a normal life instead of going to that health facility once a month. Patients in Kinshasa also showed us that actually the patient cost is far lower at these distribution points, so they spent far less time for art collection at those sites. They were out in 14 minutes compared to the 85 minutes that they would spend at the regular hospital where they were getting care. And their transportation costs were a lot less if they could go to this community distribution points, which were obviously a lot closer to their house. So costs were 3 times less at those distribution points. What did we also see? Improved health outcomes. So this graph is a bit dense, but basically the colored bars show the retention in care for patients who are in these models. Of course, follow-up time is different, so we have to be a bit careful of how we interpret this, but it does show a general trend of high retention in care for patients who are in these models. And actually the patterned bars show you how their peers who have similar characteristics but who chose not to be in such a model are performing. And actually their retention in care is lower. You can see as much here in Mozambique, 77% retain in care with the same characteristics, but not in community art groups, comparing to 95%. So this actually shows better health outcomes for those who chose to be in these models. Another advantage, of course, for the grouped models show that it increases peer support, which is and peer support in itself can be a motivator for adherence. So this patient in Mozambique also said, belonging to a group, it strengthens us, and moreover, being united, we feel mentally stronger during treatment compared to those who have to deal with it individually. So the group allows them to tackle a few problems that they have difficulty in tackling on their own. Another advantage for the healthcare worker now is that it reduces their workload. What does this graph actually show? In Malawi, we looked at clinic visits of patients before we implemented community art groups versus after. And you see that there's a drop a drop in these clinic visits, especially for the ART refill visits, reduced by 60%. So this means 60% less of those people that the healthcare worker needs to see. So that clearly speaks to the fact that if they come less often, that the healthcare worker also has less workload and don't have to spend their time on these stable patients on ART. Then also we have still few costing data, but in Kailicha, South Africa, they did look at costing of these adherence clubs, and this actually shows that the cost per patient per year in these adherence clubs was $58 compared to the ones who stayed in conventional care, which came at a cost of $109. So all in all, these models show a number of positive outcomes for as well patients as healthcare workers, but of course we need to think of what is needed for these models to function in the long run and to be scaled up. And there's a number of critical enablers which we identified. The first one is this recognition of lay cadres, which we've already talked to this morning, but clearly these lay counsellors play an important role in facilitating these models, ensuring that patients are aware that they exist, that they can enter in such a model or act on group problems which may appear, or even help in the simple drug distribution. Access to quality clinical management needs to stay ensured. I think we need to be very careful that if we engage in community-based ART delivery models, it doesn't mean that we don't have to look at what happens at a health facility. So patients still need access to a quality clinical consultation. If there's any problem, they need to be able to be referred back to regular care. A reliable monitoring system is also needed, just for health systems to be held accountable and also for us to be able to troubleshoot patients who need further care. And of course, a robust drug supply is also needed. Others have already talked around the stockouts before, so which definitely threaten these models as well. And all of that actually requires realistic planning and flexible adaptations to its context to be able to scale up at large. So in conclusion, I want to say that further scale-up of ART will demand us to look into innovative interventions and innovative ways of how to offer care to patients. And these differentiated care models do actually respond to a need of this growing cohort of stable patients on ART and their healthcare workers. But of course, we need to ensure that a conducive national framework and national policy is there to ensure that these critical enablers are in place. So if you want to read more about this, I don't know if we took the report, it should be here somewhere, but this Reaching Closer to Home report definitely explains you a bit more in detail what I've just been talking about. And we also have a number of toolkits which help countries and health facilities in scaling these models up. Thank you.
Thank you.